And now I would invite Dr. Jessica Wang. Dr. Jessica Wang, is she here? Yeah. So Dr. Wang is in the faculty of UC Los Angeles. She joined the faculty there in 2015 after excellent training at UPenn Medical School, then UT Southwestern for her internal medicine training, and then UCLA STAR program for her PhD and coronary and the cardiology fellowship. She is the director of the Genetics and Genomics Center at UCLA and looks after the Cardiovascular Genetics Clinic, Inherited Cardiovascular Disease Registry to systematically capture patients and families who have suffered devastating cardiovascular outcomes due to inherited cardiology conditions. Dr. Bang, please.
Thank you, Dr. Nora, for the kind introduction. So today I'll be giving you a sort of a whirlwind tour on some of the conditions that we see in our clinic and how that, getting genetic testing can be helpful in the clinical care of patients. I have no financial interest to disclose. Some of the bullet points is to recognize the different etiologies that can lead to a hypertrophic cardiomyopathy phenotype, and to recognize that genetic testing can help clarify diagnoses and in some cases change management. And as Dr. Robinson alluded to, the diagnosis of FH in the molecular level can help the choice of medication. And even though I have not included FH in my presentation, I'm glad that we haven't overlapped. And also to recognize that myocarditis or troponin elevation may be the first sign of a genetic cardiomyopathy, and to review common indications for cardiovascular genetics referral, and to understand the implications of genetic testing results. A lot of times I get referrals just to help look at the genetic test reports because it can be confusing for many people who are not familiar with the language. So this slide is just to spell out the definition of hypertrophic cardiomyopathy based on the American Heart Association and the European Society of Cardiology guidelines. And in general, people who have sort of heart wall thickening greater than 1.5 centimeters or greater than 1.3 centimeters with a family history that is out of expectation, like out of proportion to their hypertension, et cetera, of valvular disease. So I'm gonna try to, in the next 20 minutes or so, go through 10 cases. So it's gonna be really fast, but hopefully it'll illustrate some points. So 37-year-old female with Down syndrome and hypertrophic cardiomyopathy. She was diagnosed with hypertroph at age 20. And had heart wall thickening of 2 centimeters. She has SAM, ICU was placed, and then due to symptoms, she has surgical myectomy at the age of 35. She has a family history that's pretty strong with a maternal uncle with HCM after a heart transplant and died from head injury, and then a cousin with myectomy. Her 2 sisters were screened negative for HCM, and so family members, they might be interested in whether they're at risk for developing a condition later on in life, and so genetic testing was pursued. This is her EKG, self-explanatory, and this is her myectomy results. And so her genetic test results show a MIBPC3 genetic mutation. It's a splice donor mutation that leads to loss of function. And if there's nothing to take home from this, then this case, they will show up on the board exam as to what genes are most important for HCM. So this is MYBPC3 is something to keep in mind. And MYBPC3 encodes basically one of the modulating proteins for the contractile function of the heart. The loss of function leads to hypercontractile function of the contraction. And it's autosomal dominant in nature with reduced penetrant, variable expression. So within the family, there could be vastly different manifestations, some very mildly affected, others more. And it's thought that there could be other genetic modifiers that can contribute. Perhaps hypertension can also contribute to the manifestation of HCM. And this gene accounts for up to 40% of hypertrophy that is gene diagnosed. We'll go over in general, the diagnostic yield for genetic testing for HCM with a family history is about 1/3 to 2/3. So we definitely cannot identify genetic mutation in all of the families that have known familial transmission of HCM, but MYBPC3 loss of function mutation is a major player. And for completeness, we also looked at her chromosomes, and she has a translocation that leads to an extra copy of chromosome 21, and that's the cause of her Down syndrome. So some of the take-home points, MYBPC3 and MYH7 are the most common causal genes for HCM, and MYBPC3 loss of function is a common mechanism of disease. In contrast, MYH7 mutations are typically missense mutations that cause disease. And MYH7 is the actual motor protein that controls contractions in the heart, and a recently approved mavacamten back in April directly targets this MYH7. And so by modulating the contractile function of the heart, it can remodel the heart wall thickening in the heart. And yes, it is possible to have multiple genetic abnormalities. And so the graph on the right is kind of an old study. Now we have new genes such as FLNC and ALPK3 that adds to the pie. And so now more and more of the genetic HCM are being diagnosed. And work is ongoing to discover new genes, obviously. So case number 2, 63-year-old female Filipina with HCM diagnosed with SLE and started on hydroxychloroquine at age 40. And she took that for like more than 20 years. She was pretty asymptomatic except for hospitalization for gangrene and Raynaud's. And she took prednisolone and improved. And then later on, she was diagnosed with hypertension and then diagnosed with pulmonary hypertension. And TTE showed biventricular hypertrophy, moderate biatrial enlargement, and her pulmonary hypertension got worse, and then she was referred for genetic evaluation. Family history is negative for HCM or sudden death, and this is our EKG showing sort of classic LVH with AFib 1 year later, seems to be worsening. This is our MRI showing heart wall thickening and pulmonary artery enlarged, consistent with pulmonary hypertension. And this is her test result. So if you get one of these test results, you're probably having a headache, head spinning. These are all variants of uncertain significance, and she's got 5 of them. So within a few weeks of getting this result, this MYH gene variant was upgraded to likely pathogenic and then downgraded to VUS again. We didn't ask the lab as to what happened, but you might see this in your clinical practice. Sometimes things are upgraded and then downgraded. This is uncommon, however. Most of the times things get downgraded and not, and so what we realized that, she has a history of hydroxychloroquine usage, and so we actually recommended for an endomyocardial biopsy. And this is her biopsy result, which showed vacuolated myocytes, curvilinear bodies, myeloid bodies, and evidence of autophagal lysosome. And so with this information, we, because her genetic variants are VUSs, we table those results and give her a diagnosis of hydroxychloroquine cardiotoxicity, and that medication was discontinued. She later on continued to develop worsening, and then she died 2 years later. And so some of the take homes is that she was a Filipina of ancestry, and so people from less well-represented populations can have more VUSs because their reference populations is not as complete. And so it's not uncommon for us to see like Pacific Islanders getting more VUSs, and that's just the nature of things. Watch out for cardiotoxicity and chronic hydroxychloroquine use, obviously, and watch out for genetic and non-genetic HCM mimics. It remains unclear whether any of the VUSs found in her predisposed her to HCQ cardiotoxicity. So with any VUSs, if we don't have family history to go by, et cetera, we table those until at a later time. The vast majority of them will get down classified to benign over time, but at this point, we just don't know. Case 3, 55-year-old male with HCM developed shortness of breath, chest pain, neck tightness, leg swelling, hospitalized for heart failure, and has severe concentric LVH, EF of 40%, grade 3 diastolic dysfunction, peripheral neuropathy. And then biopsy, CMR showed evidence of infiltrative disease, endomyocardial biopsy showed Congo red positive deposits, and mass spec identified TTR with no mutation detected. ICD was implanted. Father died suddenly at the age of 85. And this is his EKG, showing an MRI showing heart wall thickening and also infiltrative pattern, LGE. This is his test result. He has a TTR VUS, and he has some additional VUSs as covered in the gene panel that we order. Because of his biopsy evidence of TTR deposits in the heart, we were able to submit the results to the genetic testing service, and then this TTR VUS was reclassified to pathogenic. And this has potential implication, as we know that there is now available therapy to treat TTR amyloidosis. Unfortunately, the patient expired prior to the approval of novel TTR therapies. This was a few years ago. But this genetic mutation has implication on family members. So we then reached back out to the patient's daughter to contact her regarding reclassification of this variant, as well as a recommendation for further management, such as monitoring. So this is his diagnosis. We need to look for TTR amyloidosis, as you may know already. Mass spec is excellent for detecting TTR from tissue to differentiate it from, let's say, light chain and other things, but it can miss genetic mutations due to sparse sampling of peptides. And so even with the mass spec showing no mutation, genetic testing is still necessary to identify the possibility of having mutation. These are the new therapies for TTR. And by the way, the TTR silencer sequence is not mutation specific. So in theory, the patisiran, vutrisiran, and inotersen that's approved for TTR with mutation, in theory should work also for wild type, but currently is not approved for people without a mutation. Case number 4, 57-year-old with HCM, 2 episodes of proteinuria, anasarca, hypertension, LVH, AF. Just sort of sounds like a fairly typical history. Mother with irregular pulses, sounds like AFib, maybe some cardiac enlargement. Besides that, no other sort of notable history. And this is his EKG with LVH and then the MRI. So he actually turns out to have a GLA pathogenic mutation. This is a genetic mutation for Fabry disease. And Fabry disease is an X-linked disorder due to processing of the lysosomal enzyme deficiency, and it can lead to small vessel disease. People are at risk for stroke and coronary disease, and as well as it affects causing LVH in the heart and kidney problems. And this particular variant actually is interesting. This is an mutation that arose 800 years ago in Japan and East Asia somewhere. And it causes a cardiac variant Fabry that does not have a renal manifestation. And so in newborn screen in Taiwan, the prevalence is 1 in 875 in males and 1 in 399 in females, so fairly common. And so it can present in the population as a later onset disease, similar to all the other kinds of things that we see in cardiology clinic. And so the follow-up is there's a special treatment, migalastat, which is a chaperone therapy for this alpha-galactosidase. And because of the sequence change that he had, he didn't qualify. And then he was started on enzyme replacement therapy. CMR show, continued progression. And there is a basic science paper showing that amiloride can affect the splicing. He has a splicing mutation that specifically could be affected by amiloride. We started him on it. He may have stabilized disease. It's hard to know. It's a little bit too soon to tell. So take home, he had a late onset of Fabry with predominant cardiac phenotype and with a fairly ordinary clinical presentation, no different from other hypertensive disease patients or hypertrophic cardiomyopathy patients. Daughters of affected males are obligate carriers, and they require routine monitoring. This used to be considered an X-linked recessive, but we know that quote-unquote carriers, having one single copy of the mutation in females can have a late onset presentation as well of Fabry disease. So case number 5, 37-year-old with DCM admitted to CCU with heart failure. Just sort of DCM, classic DCM presentation on a young individual, EF of 12%, cardiac index was 1, pretty end stage looking. Interestingly, he did not have a scar on CMR, and he was on Miranon and then weaned off and discharged home successfully. And this is his echo. And he turned out to have a MYH7 mutation. He did not have a family history. And it's possible sometimes people's family history is not accurate or not complete, but this particular mutation, interestingly, had been found in other individuals. Although those individuals did not have cardiomyopathy, they had a skeletal myopathy, and in those, there are 3 cases that were reported as de novo, meaning he may be the first individual in the family due to a novel mutation that occur between his parents and his generation. And so the follow-up is that he was started on Entresto along with all the other GDMT. His EF normalized. Because I looked back in his chart because I wanted to enroll him in one of the novel MYH7 activator trials, but it turned out he normalized his EF completely, and he did not require further treatment except for his GDMP. And interestingly, he had stopped some of his GDMT and then BNP, with a stop of Lasix, I guess, it's expected that BNP increased, but then he continued, and then he is doing fine. Family screening is ongoing. So case 6, 35-year-old with VT. He wanted to start a work related exercise program, went to his PCP, nothing remarkable, completed exercise regimen, and then started to run about 6 miles 4 times per week. At 11 minutes into his run, he felt sudden onset, just feeling very unwell, ended up in the ED, found with monomorphic VT, and then EKG saw that a precordial T-wave inversion, troponin elevation to 7.8, coronary angiogram was normal. TT showed enlarged RV size, mildly reduced systolic function, hypokinetic RV apex. He has a family history of brother dying suddenly at the age of 39. This is his VT, and this is his baseline EKG. You can see the interior T-wave inversion. And this is his MRI, showing the sort of dyskinetic RV wall as well as increased RV size. And he went ICD implantation, no recurrence on VT after metoprolol, and he was discharged. His genetic test showed a PKP2 genetic mutation. PKP2 accounts for most of the genetically diagnosed ARVC. And loss of function PKP2 variants are thought to be pathogenic, and that's why it was classified as such. And this particular variant has been reported in other patients and is also present in somewhat of a high allele frequency in the population. So it puts into question of whether there's a large component of environmental factor. So ARVC is thought to have a significant exercise element to it. So the individuals in the family with more exercise or endurance exercise history will tend to manifest ARVC more. And within a family, the disease penetrance is actually not that high. So it's a case where a genetic variant, genetic mutation can be a predisposing factor. And on top of that, you put a lot of exercise, a lot of marathons, and that's going to bring out the disease. And so in terms of the family, in terms of the counseling, it's important to emphasize the lifestyle modification, not to do too much endurance exercise. And so his follow-up is that he had further progression of his RV pathology. And at first he has some inflammation during his acute episode on PET scan, but on the follow-up, the PET scan was no longer positive. And so in the case of ARVC, you might see a positive cardiac PET FDG uptake, suggestive of acute inflammation. So inflammatory phenotype is a characteristic of arrhythmogenic cardiomyopathy. So again, PKP2 is a gene to remember. It accounts for is the most common gene in ARVC, and RV dyskinesis is a feature of ACM. Exercise is an important negative sort of adverse modifier, a risk factor for ARVC progression. Cardiac inflammation and troponin elevation is a feature of arrhythmogenic cardiomyopathy. Case number 7, this is a patient with a history of Hodgkin's lymphoma and chemotherapy, and then later on developed a lot of PVCs and troponin elevation at baseline, and then some VT, and RVEF is low, focal dyskinesis. So the reason he was referred was this question of, is this caused by prior chemotherapy or is this genetic in origin? And so this EKG is not particularly characteristic of ARVC, but the CMR is. And so the genetic tests show that he has a PKP2 pathogenic variant, again, is a loss of function mutation. And therefore, the recommendation is that to screen family members and also offer cascade genetic testing for family members. And the appropriate counseling is that the disease penetrance in the family may not be very high, but the counseling on lifestyle modifications, if people are doing a lot of marathon running, that could be reduced to just to be on the safe side. And so the finding of PKP2 mutation supports the diagnosis of ARVC. Therefore, a definitive diagnosis can help clarify the need for family screening. Case number 8, 45-year-old with 6 sinus syndrome, diagnosed with right renal artery infarction at age 38 of unclear etiology, all the workup negative, and then developed sudden onset of fatigue, lightheadedness, loss of consciousness while running at age 44, and has an older brother with similar symptom, history of atrial fibrillation and strokes. And this older brother was known to harbor a genetic mutation that may cause Brugada syndrome. So we did his genetic testing. We didn't have his information at that time, but we did his genetic testing. And so his TTE is just not really remarkable, just some mild concentric LVH. And during exercise, he has some exercise-induced atrial tachyarrhythmia. CMR was normal. EP study shows sinus node dysfunction, and an implantable loop recorder was placed. 2 months later, he had longer pauses and then developed VT episodes. So you may have guessed it, the gene is SCN5A as a pathogenic mutation. So SCN5A can cause a number of different disorders that will be listed later. And because of this diagnostic genetic test result, the patient and his family, I think he's like an actor, he wanted, they went ahead and to have an embryo harvest and then had a pre-implantation genetic diagnostic done, that they did identify an embryo that did not contain the pathogenic mutation, and they proceeded with the implantation and pregnancy of this embryo. So take home, the SCN5 encodes the cardiac voltage gated sodium channel, and then the mutations can cause, classically described as Brugada and long QT, but it can also cause progressive familial heart block, 6 sinus syndrome, familial atrial fibrillation, familial dilated cardiomyopathy. And definitive genetic diagnosis can assist in family planning through pre-implantation genetic diagnosis. Case number 9, 24-year-old DCM, VF arrest, while he was very young, when he was 14 years old. At MRI at that time showed some evidence of myocarditis. EF normalized, initially low, but then normalized. And then there's some scar that was found in the MRI. And then there's some minor changes. LVDP was elevated. He has some PVC and troponin elevation. And EP studies show easily induced VTVF, IC was implanted, and then he was, in spite of all of this, he played water polo throughout high school. And some years later, he developed AFib with RVR, and then EF dropped to 35 to 40, and with a LV dilation. So he turned out to have an FLNC, a pathogenic mutation, and consistent with the diagnosis of arrhythmogenic/dilated cardiomyopathy due to this mutation. And we found out this mutation was inherited from mom, whose EKG may have shown maybe BB epsilon wave. And her workup, unfortunately, due to dad's health, she didn't do her EKG for the longest echocardiogram for forever, and but mom was adopted, and so her family history is unknown. That's why we don't have a family history. Sister carries the FLNC mutation. Her workup has been normal, and brother carries the RBM20 VUS, and his workup has been normal. At that time, we thought maybe the RBM20 could have been a modifier, and that's what we tested. Normally, we don't test family members with the VUSs. And later RBM20 was downgraded to benign. So we have FLNC in the family, perhaps with sort of variable expression because mom seems to be okay. And so take-home myocarditis in a young individual can be from COVID or other things, but it could also be a feature of early ACM. Loss of function in FLNC is a known mechanism of disease, and the body of literature behind it is accumulating more and more, and so we can have sort of a better understanding of sort of a typical presentation for it. It can present with LV involvement, ventricular arrhythmia, and sudden death. And in early phases, the echo may be completely normal, and then the MRI may be the only test that will show some structural abnormalities in the early phase, such as some scars. Troponin elevation in young individuals should never be ignored, obviously. They shouldn't just leak troponin. Case 10, 28-year-old Tad developed pectus and then had corrective surgery, and then present with dilated aortic root, 7.5 dissection, all the way down to the aortic bifurcation. And then after surgery, he had just hissings of his Bentall procedure and Bentall aortic root, just sort of surgery and then soon complication afterwards, and then he had post-op AFib. So his exam, Marfan systemic score is 7, Baton 5 out of 9, some high-arch palate. And so it turns out to have a TGF-beta receptor 2 VUS that was called out as VUS. And so what we did was that then we did parental testing, and we showed that his parents did not carry this mutation, which established then this variant to be de novo. And because of this information, we were able to get it up-classified to pathogenic. And with this result, he ended up with a diagnosis of Loeys syndrome due to mutation in TGF-beta receptor 2. And later on, he has some residual dissection flap, and then further progression of his aneurysm to 5.2. So people with Loeys are at risk for further worsening, and so blood pressure control is critical and crucial. But the good news is that he was, the last time I saw him, he was expecting a baby in 5 months. That does not carry this mutation, and so that's good news for him. And so take home, TGF-beta receptor 2 is a gene associated with autosomal dominant Loeys disease syndrome and can share similar features as Marfan syndrome. But the DIA I mentioned, which it dissects, is younger than Marfan in general. It could be younger than Marfan in general. And so the surgical recommendation can change based on the genetic test results. So it can affect surgery, timing, as well as reproductive choices. So who should get genetic testing? So it's people with a confirmed or suspected diagnosis of inherited cardiovascular disease, or individuals at a high risk due to a previously identified pathogenic variant in their family. And so some of the information we use to evaluate a patient, very, very important, is the disease phenotyping. Understanding whether it's LV involvement, RV involvement, and where locations of the aneurysms are critical in terms of when we're matching up gene to disease. And when we have a VUS, it's important to know when to go the next step to do the family segregation studies. And a second element is the comprehensive family history. In a typical visit, in a typical cardiology visit, we don't always have that time. That's why we have genetic counselors to sit down with the patient to go through that family history. And because of the diagnostic yield of genetic testing is not complete, there are certain families that may even have negative genetic testing, but their family history is very, very strong. In those individuals, we don't say that a negative genetic test means no genetic condition, for sure, right? That family history is flagging something. So that family history is just as important as the primary phenotyping of the patient. If these elements exist, then the next step is to identify the most appropriate person for testing. In general, we'll find the most severely affected individual. That individual is the most definitive in telling us who has the problem. And also sometimes the younger people that present early may harbor more than one genetic mutations. And so when we're doing cascade testing, we want to make sure we test the most severely affected. And so these are the components of a genetic evaluation. And so we'll, the family history, the insurance issues, and then provide resources to families. And so there's a lot that goes into a visit. Our counselor spends like a long time talking to patients. And Genetic Information Non-Discrimination Act applies to genetic information. It protects against health coverage and employment, but it does not extend to life insurance, disability insurance, and long-term care insurance. So before sending genetic testing, especially for unaffected family members that don't have a personal diagnosis, we'll go over the genome information to make sure they're aware of the potential issues. And nowadays, there are multiple players that will pay for the testing. Self-pay in general is $250, so it's not bad at all. But their industry sponsors will pay for these tests as well. The turnaround is maybe 4 to 6 weeks. It can be done through saliva. We send it to the patient's home. It's very easily done. And we often do these visits over telemedicine. The genetic interpretation of results. So there's this is sort of like a black box to most of the community. There's population data that goes into it, whether parents carry the variant, the previous segregation from other families in the world, functional data in the lab, computer algorithms. So all this go into the algorithm to call something pathogenic or non-pathogenic. And so it's kind of a complicated process, but when it's positive, it's something that we can act on, something we can add on to screen family members and to do pre-implantation genetic diagnosis. When it's a VUS, it's harder. We will take the next step. If it looks like a promising VUS, then we'll try to set up segregation for the family members. And as more data accumulate, there will be fewer and fewer VUS, but unfortunately nowadays when you send a genetic test, it's more likely than not that you'll get a VUS. And negative does not mean that there's no genetic disease in the family. The family history is a better indicator, and we may consider retesting in the future, especially if family history is strong. Okay, thank you very much for your attention.